Dear colleagues, on behalf of WeOncologists, ESO presents, welcome to this presentation on the challenges for clinical practice with immune checkpoint inhibitors in non-small cell lung cancer. I'm honored to have my collaborator, Dr. Luis Castelo-Branco from Portugal, here with us. Welcome, Dr. Castelo-Branco.
Hi, Jill. Thank you so much for the invitation. It's an honor to be here with you today. And congratulations also for this great collaborative project between We Oncologists and the European School of Oncology.
Thank you very much. It's actually a pleasure to have you on these presentations. These presentations are only possible due to great collaboration from my colleagues. For those of you that don't know, Dr. Castelo-Branco is a clinician currently doing his doctoral work on immune checkpoint inhibitors at the Portuguese School of Public Health in collaboration with Institut Jules Bordet, and he's also a fellow member of the Oncodistinct network that is headed by Professor Ahmad Dawada. Together, Dr. Castelo-Branco and I are working on a survey that is being conducted by Institut Jules Bordet and the Oncodistinct network in order to determine the challenges for clinical practice with immune checkpoint inhibitors, which gave us the idea for this particular presentation. Now, the concept of immunotherapy for the treatment of cancer has been around for a long time. However, it did not become a reality until recently, thanks to the work of Dr. Allison and Dr. Honjo, of which they were awarded the Nobel Prize for their discovery of cancer therapy by inhibition of negative immune regulation. Their work revolutionized the field of melanoma and thoracic oncology, and many trials are currently being conducted with these. Immunotherapy has cemented its place in oncology that is now addressed as the fourth pillar of oncology right after surgery, radiation therapy, and chemotherapy. This is all thanks to the work of immune checkpoint inhibition. These are drugs that target checkpoints and activate the immune system. But why all the noise? Well, it's more than just hype. These treatments have shown amazing results. For example, if we looked at the survival rates of melanoma patients by the type of treatment, look at the curve for the historical existing treatments compared to those receiving anti-PD-1. That's around 40% survival after 5 years after diagnosis with anti-PD-1 compared with 2% with the historical existing treatments. With these results, it was only a matter of time before more trials started, and with that, an increase in the approval of immune checkpoint inhibitors by the Federal Drug Administration. The only natural step in academic oncology was the increase in the publications with immune checkpoint inhibitors, with ipilimumab, nivolumab, and pembrolizumab leading the charge. However, when we look at some of the examples of our patients, there is no denying that these therapies have made a huge difference. If we look at this before and after example on this particular melanoma patient treated with anti-PD-L1 immunotherapy, we can see the drastic effect that these therapies can have. However, by now we already know all of the positive sides of immunotherapy. However, the more we find out about this treatment, the more we find out that there is a lot we still don't know. Hence, we initiated a survey on the challenges with immune checkpoint inhibitors, for which we all who work clinically need to know.
So, this is a fascinating and rapidly changing environment, as Jill mentioned, but can we identify important challenges for clinical practice nowadays with immune checkpoint inhibitors? And what are the nature of those challenges? We published it last year on Oncology Pro precisely on this topic, where we tried to explore important gaps of evidence for clinical practice with immune checkpoint inhibitors. There was an important background information and knowledge acquired that encouraged us to develop and go ahead with this survey. Challenges can come mainly from clinical trials limitations or patient selection, particular clinical behavior of immune checkpoint inhibitors, and also the boom of evidence research becoming very hard to be updated on all evidence coming on. So when you look on for clinical trials limitations, first, patient selection with elderly frailty patients, autoimmune disease patients, patients under steroids with brain metastases, higher ECOG scores, among others. So those are important populations that have been excluded from most of immune checkpoint inhibitors trials. And these are important populations also with cancer that potentially can benefit from these innovative treatments. So we need complementary data that can help us to better define the role of immune checkpoint inhibitors in this population. We need also to look for the time on follow-up. We know that checkpoint inhibitors take more time to be, might take more time to be effective, but we can have a long-term benefit. So, but many trials are designed for a relatively short period of time. With immune checkpoint inhibitors, maybe might be important to better assess long-term benefit, the rate of secondary resistances, role of rechallenging with checkpoint inhibitors on those cases, and all that on different tumor settings, among other important things that can be we can raise more evidence with a long-term follow-up. Also, classic outcomes might not be adjusted to immune checkpoint inhibitors, particularities on most of the clinical trials. So immune checkpoint inhibitors have some clinical particularities very different from classic chemotherapy or small molecules therapy, and we might need proper outcomes to capture their magnitude of benefit, as we'll explore on further slides. So generally saying, checkpoint inhibitors take more time to be effective comparing with classic chemotherapy, and median outcomes such as median PFS or median overall survival are not the best outcomes to assess immune checkpoint inhibitors alone. So it's now known the potential long-term benefit with immune checkpoint inhibitors, and probably landmarks on time, rather median assessment, and the time to plateau on Kaplan-Meier curves can be relevant outcomes here that can be more explored in further research. And monotherapy can give long-term benefit, as we know already, and the great example with melanoma. But the best combination and sequencing with other therapies, as long as finding reliable predictors of response, are key to help improving results and in different tumor settings. This is a promising ongoing process and research field that we hope to see more positive results in the near future. As we know, we have some new particular patterns of response that can be observed with immune checkpoint inhibitors as the so-called hyperprogression or pseudo-progression diseases. So in some cases, there is an apparent early progression after starting treatment, but followed by later radiology-confirmed response, the so-called pseudo-progression disease, which can be mediated by inflammation on tumor sites, and it is important to distinguish it from real tumor progression. Also, some tumors can rapidly progress with patient clinical deterioration after starting immune checkpoint inhibitors treatment. That's the hyperprogression disease. But how much immune checkpoint inhibitors can trigger that response, or if it's just tumor more aggressiveness behavior regardless of treatment? And having predictors for such cases are still not very well known, and we clearly need more research and more data to better understand these atypical patterns of response. This is clearly another exciting research topic. When you look for toxicity, we know that immune checkpoint inhibitors side effects are mainly driven by immune-related adverse events. So also complex and any organ can be affected. There are already very useful guidelines based on best evidence available, such as from ESMO, ASCO, NCCN, or SITC. So here just we highlight that indeed any tissue can be affected by immune-related adverse events, and measurement should be adapted to type and severity of toxicity. It's important to be aware of these particularities and to clearly be adapted to each individual case. Here, just to highlight the complexity, although we have this common immune-related adverse events concept and managed by immunomediated drugs, but it's still complex, and there's all tissues can be affected, and the algorithm is not so easy like that, and it's important to adjust treatment for each individual case. In this very rapidly changing environment, as we spoke before. A great concern and a legitimate concern from all of us is how could we integrate all this data into our practice? And let's say it's impossible to be updated in all evidence coming so fast, like Jill explored before. So here is just a recent reflection on how that could be done, and this is published at Current Opinion Oncology, and we're just highlighting some points. How can we be updated in this so challenging environment? The first thing, let's say, is knowing the general characteristics of immune checkpoint inhibitors, having a good background general knowledge on immune checkpoint inhibitors can be an essential starting point. When you look, we always should look for our clinical guidelines, but there's hundreds of publications coming very rapidly. So might be also important to pay attention to these new publications. So it takes time between those boom of publications get translation into practice, and we can restrict those gaps with proper research, such as in PubMed, and of course always adapted to local context and regulatory possibilities in your own reality to provide those treatment options to our patients. I can highlight also, like, choose wisely events to participate and be updated. There are hundreds of events going on and more are coming. So choosing where to go and adapt it to our needs could be very important. And another important aspect is to chat with our colleagues. So that might be of mutual benefit, since many questions might be common and raised, and that is raised by our clinical growing experience. So speaking and chatting and sharing our experience with our colleagues might be really of mutual benefit. And so finally, deep learning machines in the near future. So yeah, artificial intelligence is coming to be an important tool across medical fields, and probably also helping optimizing the use of checkpoint inhibitors in the future. So we can expect that to be a reality and to help us to better use to optimize our practice, including with checkpoint inhibitors. So we can ask if there are important unmet needs with immune checkpoint inhibitors, but I guess we all agree, yes, there are. But exactly which are still the major challenges for clinical practice, and how can we close those important gaps of evidence? Well, we can do it doing clinical trials, perhaps more and more coming, and perhaps more adjusted to address those specific particularities, challenges with checkpoint inhibitors. It can also be used real-world validated data to complement evidence from clinical trials, and I highlight that it's important to use data that it's real, validated, and important for our practice and getting collected from our real-world setting. But also capturing clinicians' opinions in this rapidly changing environment can be important to understand physicians' practice perception, and also to identify the most relevant gaps of evidence that is being raised for clinical practice and questions that we have on our daily basis. So many important knowledge and clinical experience might not be fully captured yet by clinical trials and real-world studies, and that was an important reason for us to go ahead with our survey. So we thought about asking physicians' opinion on relevant challenges for clinical practice with immune checkpoint inhibitors in lung cancer. Well, we choose lung cancer considering the important public health impact of this disease and the accumulated experience with checkpoint inhibitors over last years by many, many clinicians all over the world. So we hope it can help us to identify doctors' opinions on most relevant challenges for clinical practice with immune checkpoint inhibitors. Also share doctors' current practice on those challenges, and to optimize perhaps the design of further research, more focus on real clinical unmet needs that is being raised and shared by our colleagues from all over the world. And honestly, all contributions are really important to us, and we are very grateful if you could answer and share our survey. We are also very grateful for the institutional support from Institut Jules Bordet and Oncodistinct network in this project.
You're completely right, Luis. With a 5 year survival rate of 56% in localized disease and a 5% in metastatic disease, lung cancer accounts for 1 in 4 cancer deaths and is definitely a public concern to find therapies to improve these numbers. Now, thanks to the development of checkpoint inhibitors, many of our patients are actually receiving the benefit from these therapies, but at the same time, doctors are also accumulating the experience with these treatments. And most of the focus right now is being put on the toxicities of these treatments and not on what we don't know. And that's what we're trying to do. So that's why, along with this presentation, we're actually releasing the survey in order to gain more knowledge and help us move forward in discovering the attitudes of many of you regarding checkpoint inhibitors. Now, we really appreciate all our colleagues taking the time to watch this presentation. We also encourage all of you to take this survey. It will take no more than 10 minutes, and it will definitely help us advance the field further. So on behalf of Institut Jules Bordet and the Oncodistinct Network, my collaborator, Dr. Luis Castelo-Branco, and myself, we thank you in advance for your help, and we look forward to continuing to move this field forward. Thank you, Dr. Castelo-Branco, and thank you all for your presentation.
Thank you so much again for the invitation, Jill. It was a pleasure, a real pleasure to be here with you today. And I'm really happy to discuss any questions or topics that might be raised by our colleagues and keep dialogue with them after this presentation.
Absolutely. And along with this presentation, if you look at the comments page, you will actually find a link to the actual survey that is being conducted through SurveyMonkey. So thank you all for your attention, and we'll see you on the next presentation.